Okay.
Alrighty, so there's a sign-in sheet and a packet going around. For those of you who don't know who I am, my name's Kyle Berry. I'm the stroke program coordinator here at Elkhart General. And my role is basically to make sure that Elkhart General keeps its designation as a primary stroke center. So we're certified as a primary stroke center through the Joint Commission, which means that we do a really good job of taking care of stroke patients. The ER is so important because you guys are the first ones that see probably 90–95% of our stroke population. So you're the gateway, and you're the ones that take care of all of the acute treatment, things like giving IV TPA, transferring for mechanical thrombectomy, evaluating for surgery for intracranial hemorrhage. So stroke is kind of it's an important skill to get down, which is why I'm kind of here talking to you about it today. So a real cornerstone of what we do down in the ER is our code stroke procedure, which I did bring our code stroke binder, which we have 2 of these in the department. There's one on the bookshelf over by the secretary in the pod, and then there's one that lives on the specialist on call SOC video cart, also known as Sheldon. So if you're running a code stroke and you're not really sure what to do, or you kind of feel lost, this is a good resource. But in your packet, I gave you really the most important piece of information in the binder, which is our code stroke checklist. Okay, so thank you. If you're just looking for a 1-page itemized list of all the things that you need to do during a code stroke, this is the document that you want to pull. So there are blank copies of that in this binder here that you can take and you can write on, and there's also just a laminated one that you can just, go down and look at. And so that's kind of what I'm going to use as my speaking points with you today. So first off, when do we call a code stroke, or what kind of patient do we call a code stroke on? Basically, we're looking for a patient that is having stroke-like symptoms, and that's going to be your FAST assessment: face, arms, speech, and time. So again, we're looking for patients that have unilateral neurological symptoms. So stroke usually just affects one side of the brain and one side of the body. So patients that present with bilateral symptoms like bilateral arm and leg weakness or bilateral vision loss, we've seen that, or just kind of unspecified altered mental status or decreased responsiveness. Those patients really aren't the ones that we're looking for to call a code stroke on, but if you see someone that comes to triage or they're coming in by ambulance and they have that clear-cut weakness on one side of the body, numbness or tingling on one side of the body, facial droop, loss of vision or vision changes in one of the eyes, or the changes in speech. So the slurred speech, the garbled speech, confusion, those are the kinds of patients that we'll go ahead and call a code stroke on. So the first thing, we're looking for stroke-like symptoms, your FAST assessment, F-A-S-T. The second most important piece of information that we need is the time that they were last seen normal, okay, without any stroke symptoms at all, because that really guides what kind of treatments we can offer that patient. So the very top of this code stroke checklist, it basically deals with time last known well. From 0 to 6 hours from time last known well, we're going to always call a code stroke on that patient, because we can give IV TPA, the blood clot dissolving medication, up to 4.5 hours from time last known well. And then up to 6 hours, there's certain rules for mechanical thrombectomy, also known as clot retrieval, where we will ship the patient over to Memorial Hospital. They'll do basically a heart cath. They'll go in through the femoral artery, go up through the aorta, but instead of stopping at the heart, they're actually going to go up through the carotid into the middle cerebral arteries in the brain to grab onto that blood clot and pull it out. Okay? There's certain criteria for that procedure to be done, and the biggest one is the patient's time last known normal, or time last known well. So from 0 to 6 hours, we're going to call a code stroke all the time. Okay? Once we get into the 6 to 24-hour window, the rules change a little bit because we can't give TPA to that person. Again, we can only give TPA up to 4.5 hours from time last known well. So the only thing that we can offer that patient is mechanical thrombectomy, clot retrieval, which means transferring them over to Memorial Hospital for that procedure, because it's not something that we offer here at Elkhart General. To give you a perspective of how often we do this procedure, out of 1,000 patients that we evaluated last year, 18 were transferred. Okay, so this is not a procedure that we're doing for all patients. You really have to be a good candidate for the procedure to be beneficial. Okay, So between 6 and 24 hours from time last known well, we're looking for one of two things. The first one is what we call a fast ED score. Basically, in your packet here we have it's a big long flow chart of our code stroke algorithm. I'm not going to go through this entire thing, but if you're wondering how a code stroke patient flows through the ER, this is the chart that you can refer to. But after the algorithm is a page that looks like this. This is the BFAT, or the FAST ED assessment. And what this is designed for is actually for EMS providers. So this is for bouncing around in the back of an ambulance to determine what is the probability that this patient has what's called a large vessel occlusion. A large vessel occlusion is a big blood clot in a large blood vessel in the brain, i.e. your middle cerebral arteries. Those are the kind of clots that the catheter can actually grab onto and pull out. So if the patient has a very mild stroke, chances are that blood clot's very small, it's very far downstream, and the catheter just physically will not be able to get there. You're actually going to do more harm than good trying to dig around in that blood vessel to try to pull that clot out. So the stroke actually has to be severe enough, and the clot has to be large enough for that catheter to be able to grab onto and pull out. So this procedure, mechanical thrombectomy, is not for mild strokes. These are for the severe strokes. So this scale here identifies the probability that the patient has one of those severe strokes. So we're looking for things like, does the patient have drooping on one side of their face? Do they have weakness in one of their arms? Do they have speech changes? Do they have deviation of the eyes? Are they kind of always looking off to one side, which we call neglect? These are the patients that are laying in the bed and they're always pulling to one side. Their eyes are deviated, and you're working over here. You're like, hey, look at me over here, and they're just, trying to climb out of the bed this way. That's what we call neglect, because they've lost the awareness that half their body exists, okay, which is indicative of a severe stroke. And then we're looking for that, again, denial or neglect. If the patient isn't aware that their arm exists, you're doing the pinching of the fingers, and they're not withdrawing, or pinching of the toes. And again, these are the patients that are usually climbing out of one side. They don't attend to this side at all. And that could be with vision too, like they'll be blind in one of their eyes. So you'll be flicking your fingers in your eyes and they won't blink, okay, on the affected side. So basically, the FAST ED is kind of an approximation of the National Institutes of Health Stroke Scale, the NIHSS. So really with the NIHSS, we're looking for a score of 6 or greater. With a FAST ED, we're looking for a score of 4 or greater. So the FAST ED is kind of a simplified NIHSS that we can use out at the triage desk. So if a patient comes in, I went to bed at 11 o'clock last night, I woke up at 8 o'clock this morning, and I'm having weakness in my arm and my face is drooping, okay? So that patient's time last known well is 11 o'clock last night. So we can't give that person TPA if it's 8 in the morning, okay? Because we don't know if that stroke happened 10 minutes after they went to sleep or 10 minutes before they woke up this morning. So the only thing that we could potentially offer them, because they're in that 6 to 24 hour window from time last known well, is mechanical clot retrieval. So what we would do out at the triage desk for that patient is we would do their FAST ED score. If their face had some droop, we would give them a 1. They have some arm weakness, maybe that was a 1. Maybe their speech is normal, there's no eye deviation, there's no neglect. So then in that case, their FAST ED score would be 2. Okay, we're looking for a 4 or greater to activate a code stroke on that person. So that patient is not going to be a candidate for clot retrieval. We're still going to triage them probably as an ESI of 2. We're going to get them back. We're going to do a head CT real quick, but we don't need to, page it overhead, get everyone to the bedside right away, because the patient's not going to be a candidate for acute intervention. Okay, they probably had a stroke, but there's not really anything we can do about it at this point. Okay. So, and another thing is that if the patient walks up to the triage desk, they're probably not a large vessel occlusion. Again, these are very severe strokes, usually with a leg weakness, arm weakness, decreased level of consciousness, neglect, those kinds of symptoms. These patients usually present by ambulance. And our EMS providers are doing this scale. What they're actually supposed to do, if a patient scores high enough and they're within that the 0 to 6 hour window, they're going to bypass us. They're going to take the patient straight to Memorial. If they're within the 6 to 24 hour window, they will stop at Elkhart first. All Alrighty, any questions on that? So again, from 0 to 6 hours, we always call a code stroke. You don't need to worry about the fast ED score. Between 6 and 24 hours, do a fast ED score or an NIH stroke scale first. If you feel comfortable with the NIH, you can do the whole scale if you want, but if you're out at the triage desk, it's really not practical to do a full NIHSS just because how long it takes, and you gotta do leg strength too.
You guys do Bend or Cincinnati stroke?
So EMS, yep, they will do Cincinnati.
I guess I'll give it back. I'm the EMS side of things.
Okay.
I'm a medic, so.
Yep, they'll do that first, and if
Yeah.
the patient screens positive, then they'll move on to the fast ED.
Okay.
Now, is there a protocol for how quickly to get someone back to CT
Mm-hmm.
once they arrive?
Yep, so our goal is 20 minutes from arrival.
Okay.
Yep, everything that we do with the code stroke is timed. EKG, X-ray, CT scan, CT interpretation, IVTBA, CTA of the head and neck, how fast the physician responds, how fast the neurologist responds, if we have to use teleneurology. So literally I take every single time off the chart. Okay, so if we call a code stroke, the clock is ticking. So that's why we move so quickly. So yeah, 20 minutes is our goal for CT. So from triage, we will go straight back to the CAT scanner as long as the patient's stable, their ABCs are okay, they're not bleeding out or, can't breathe. We just go straight back to the CT scanner. It's not uncommon that we'll do the scan before they're even registered and register them afterwards. That's how quick we try to move. We get a chest x-ray while we're in CAT scan, and then after CAT scan, we usually go back to the room, and that's typically where the ER physician will meet the patient. Myself and the neurologist, we're here Monday through Friday, 8 to 5. So if it's during that time, we will usually meet the patient in CT scan or the ER room. If it's after hours, we use a teleneurology service, which we'll talk about how to get a hold of them. So we've done our fast ED, we're gonna go ahead and call a code stroke on this patient, and so now we move down into the actual checklist here. So the first thing that we just need to make sure that we keep our secretary in the loop if we're calling a code stroke. They're the ones that usually page it overhead for the department. They also send out a page to our code stroke pagers, which go to lab, myself, and the neurologist that's in-house. So we need to make sure that this page goes out, otherwise we may not show up. And the other thing is that after hours, they will go ahead and start the process of calling specialists on call, our teleneurology service. So the only thing you guys typically have to do is move the cart into the patient's room. Okay, so they go ahead and take care of submitting the consultation request. So again, if it's Monday through Friday, 8 to 5, you're gonna get myself and the in-house neurologist. We're gonna come in and we're gonna take over that code. Okay, we're gonna tell everyone what they need to do and make sure everything's done. But if it's after hours, because our neurologists are technically on call 24/7, they usually work 3 weeks in a row so they can sleep at night so they don't go crazy or more importantly quit. We do use a teleneurology service specialist on call, SOC Sheldon is what a lot of people will call it. And so that's basically the big TV that's by T6. It's basically just a big Skype. There's a camera that the neurologist can control, and they're gonna come on screen. The goal is within 30 minutes of when we submit that consultation request. And they're gonna do an NIHSS with the patient, and they're gonna determine, is this patient a candidate for IVTPA, and are they a candidate for mechanical thrombectomy? And once we answer those two questions, that's the end of the code stroke. We're just trying to determine, can we treat this patient? Can we reverse their stroke from happening? Okay. The steps after that are we get them upstairs, do a brain MRI and a stroke workup to figure out why the stroke happened. Okay. So just make sure your secretary knows that, T6 is a code stroke and, what their name is and the information that they need to activate SOC. Our first goal is to get that non-contrast head CT. We want to determine, is that head CT going to be negative, which is probably going to be about 75% of the head CTs that you do, they're going to be negative, or is this a intracranial hemorrhage? Okay, because the treatments for those two things are very different. If the head CT is negative, we could do TPA, could do thrombectomy. If it's an intracranial hemorrhage, we're actually going to cancel the code stroke and we're going to call neurosurgery. Usually the goal is to get their blood pressure down below 140 as quickly as possible, reverse any Coumadin, Pradaxa, Eliquis, Xarelto that they're on, and then see if they're a candidate for surgery. After we get the head CT, we'll get a chest x-ray when we're in the CT room. That will be going away pretty shortly, but you'll hear more about that soon. We're gonna get a bedside blood glucose because hypoglycemia can easily mimic stroke-like symptoms. So if their sugar's 50, they might have some decreased responsiveness or some weakness that we can, give them some D50 and they'll perk up pretty quick. We're gonna start the NIHSS, which is the big standardized stroke scale. How many people are certified to do the NIH? Okay. You have to recertify every year, so if you're gonna be working in the ER, you'll have to get certified at some point. That way you can do the assessment. It's a score from 0 to 42. You can have a stroke with a score of 0, but the worst that I've seen in over 3 years that I've been doing this was a 31, and that patient was intubated with no sedation. Okay, they were completely unresponsive, so I've never actually seen a full 42, but again, anything over 6, if they're 6 or higher, they're a possible large vessel occlusion, and that would be a possible thrombectomy candidate. Okay, so if you see a score of 6 or greater, that's probably a moderate to severe stroke
Use on the NI,
on the
the
NIH.
stroke scale.
Mhm.
Okay.
A 4 or greater on the FAST ED, 6 or greater on the NIH. In the stroke binder here, if you are rusty with your NIH, which, the first year that I did this, I went by the guide pretty religiously. We have nice paper cards that have the pictures on them, and there's a pull-out with the sentences, okay? So don't throw this away, this can be wiped down, and put back into the binder, so please don't lose these, just because I have to keep ordering more. There's a Spanish version, okay, so if you have a Spanish-speaking patient, we can use the Spanish words on them. And then,
Now, I have a question for you on that, Kyle, because I was
Mhm.
watching the video, doing the online module for the NIH. So if people can't read, obviously, the interviewer was reading it to, like, can you say this after me?
Mhm.
If that's an appropriate thing to do.
Yep.
Okay.
a couple of quick shortcuts, like repeat after me. There are no ifs, ands, or buts. You're looking for that dysarthria. For the aphasia, what's this? Can you tell me what this is? What's this?
Right.
You're looking for them to be able to recognize objects and understand commands.
Okay.
So
Okay.
if you have an illiterate patient or a patient that has visual deficits, you can do some of those tricks
Okay.
to get around it.
Perfect. Thanks.
So there is an NIHSS section in the binder here. So basically, if you turn to the NIH, there is a detailed guide that kind of tells you what each of the scoring items is. So I used this for about the first year before I actually did it enough where I memorized it. Okay, so there's no shame in using this. The place that we document the NIHSS is in iView, so if you need to look where that is documented, this is a screenshot of FirstNet for you. And then there's paper versions of the guide. You can take these and you can write on them. These aren't part of the patient's chart. This is just a worksheet for you. The place that you need to document the NIHSS in iView. Okay, but this will help you score the patient. Which again, if it's during the day, you won't have to worry about that because myself and the neurologist will take care of it. But if it's after hours, just because SOC can't access our charts directly, we do have to enter in that NIH score. Because typically they're just going to say the patient is a 7, but what did they score for? Do they have weakness? Do they have ataxia? Do they have a visual deficit? We really don't know, okay, unless we put it into the chart. So again, we're looking for that score of 6 or greater. We're going to get a 12 lead EKG because if we're worried about clots in the head, I have seen acute coronary syndrome and stroke occur at the same time. That does happen, rarely, but it does happen. Chest x-ray if it wasn't done back in CT scan. And then phlebotomy, again, they should be paged. They should meet you at the room when you get back from CAT scan. And we're just going to get CBC, BMP, PT, INR, PTT, and a troponin. Okay, basically just some basic labs, looking at coags, make sure there's nothing else weird going on.
What's the point of the chest X-ray? Like, what are they looking for with that?
We're looking for aortic dissection.
Okay.
Obviously, you wouldn't want to give TPA to someone with a dissection.
But you said that's going away.
Just because the incidence is so rare that the Joint Commission no longer recommends it as a routine. If the patient has chest pain, go ahead and get it, but if they're asymptomatic, no shortness of breath, it just kind of creates a speed bump in between CAT scan and TPA.
Okay.
So that was one of the big worries when TPA first came out in the 90s, and it's kind of slowly, just because the incidence is just incredibly low. So getting a blood draw, with the blood draw, let lab just come in and draw the blood. They're typically going to be able to draw that blood faster than looking for an IV, and this is a code. Okay, so we can have someone starting an IV on this arm, someone drawing blood in this arm. The reason it's important is because we have 45 minutes from when the patient hits the door to get our lab results back. The reason for that is if they come in and say, yeah, I take Coumadin, we can't give TPA if their INR is greater than 1.7. So we need that blood immediately because it has to spin on a centrifuge for about 12 minutes by default, and then the analyzer has to analyze it. So just let lab come in, let them draw their blood, and let them get it downstairs. Okay, don't wait for, you know, oh, we're starting an IV, I can get you blood, because, you know, if you miss on the first try, then we gotta go somewhere else, and we're just creating delays, so.
Well, does lab send those labs down with like a special sticker that the lab recognizes as?
It's
those
a
need
sticker
to
right
be-
here.
Okay,
And there's also a cowbell down in lab, so when they see this sticker coming through the tube system,
nice.
they ring
I
it.
love it.
Yeah.
I wanna
They
ring
got a
the
good
cowbell.
system. But the biggest delay is just getting the specimen, so just let them come in and get that blood. And if you don't see them, if they don't respond for whatever reason, if the page didn't go out, or if they were drawn in another room, just try to find them as quickly as possible. Alrighty, we need a weight, so make sure that your code stroke patients are on a weight bed, so when they're in CT, especially if they come in by triage or EMS, get a weight bed outside the door while they're in CAT scan, because we do need a measured weight so we can dose that TPA accurately. And then finally, the last thing is that all stroke patients need to be kept NPO until we do a bedside swallow screen. So stroke typically affects people's speech and by extension their ability to swallow. So if we just give them pills or something, they can aspirate and their stroke can quickly turn into an aspiration pneumonia. 2 people have died in this hospital from that, from aspiration pneumonia related to stroke. Alright. One refused to be NPO, he just kept eating until he died, and then the second one was improperly screened. So, on swallow screens, there is a section in the binder here that covers bedside swallow screenings, but it's very simple. There's a copy of the policy in here, it's 1 page. I can summarize it in a couple of sentences. Basically, you take 90 cc's of water, which is 3 medicine cupfuls. The patient has to drink it continuously, gulp, 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 without stopping. There shouldn't be any coughing, choking, wet vocal quality, drooling out of the side of the mouth. And again, the most important thing is continuously. They cannot stop. If they stop halfway because they can't down it, 3 ounces is not a lot. Okay, that's like that much. So they have to do it continuously. It can be with or without straw. The patient doesn't even have to hold the cup. Okay, they just have to be able to swallow. If they can do that, then they pass, and there's a 95% chance if we took them down and did a video swallow study that they would pass. If they start coughing, if they start choking, if they start drooling, if their vocal quality sounds really wet, if they stop midway, they fail. And they have to be evaluated by speech therapy doing a more formal swallow screen. Okay.
So that's the first step on our half is doing that screening and then going from there?
Mm-hmm.
Okay.
So if you have to give the patient anything by mouth, like aspirin or any blood pressure medications, or if they're just like, I'm thirsty, we have to do the swallow screen. Okay. And this doesn't just apply to the code stroke population. In your packet here, there's another page. It's the very last one, which is a mnemonic. So basically, we have this population that comes in code stroke. Their last known well is either 0 to 6 or 6 to 24 hours. But what about the people that come in that started a week ago? I've been feeling like this now for about 3 weeks now. You know, whether it be weakness or other symptoms that could be stroke mimics, things like headaches, dizziness, vertigo, seizures. We bring a lot of those patients into the hospital and we do stroke workups on them. Now you notice a lot of those diagnoses are very vague. How many dizzy patients do we see in the ER? How many headache patients do we see in the ER? But the point is, if we bring those patients into the hospital, the very first test we typically do is a brain MRI. And if someone doesn't have a known history of cancer, the only reason we do a brain MRI is we're looking for a stroke. To explain their dizziness, like if it's in the cerebellum, to explain new onset seizures, to explain new onset headaches. Okay. Or if they had this stroke a week ago and their head CT is negative, you know, we're looking for like a small lacunar stroke. Okay. For those patients, just because they're not a code stroke, their swallowing could still be affected. So we still need to screen that population. So this mnemonic here was recommended by the Joint Commission. It's called CT CLAM. Basically, if you are taking care of any neuro-ish patient, headache, dizziness, vertigo, migraine, seizure, altered mental status, or stroke-like symptoms, facial droop, weakness, numbness, tingling, changes in speech, changes in vision, difficulty walking, like ataxic gait. If we do a head CT on them, if we give them clonidine, labetalol, aspirin, or meclizine for vertigo, for blood pressure, looking for any stroke or intracranial hemorrhage on the CAT scan, do a swallow screen on them. Because if this person gets admitted to the hospital, there's a 90% chance they're gonna fall into our stroke bucket. And if we don't screen their swallowing, we fail to measure. Okay? So I'm not asking that we do swallow screens on everybody that comes into the ER, but if they're coming in for any kind of neuro complaints, headache, dizziness, vertigo, changes in vision, stroke-like symptoms, altered mental status, we should probably screen their swallowing, especially if we do any of these interventions on that patient, which I will tell you, we CT 100% of those patients, okay? Because they're looking for strokes, they're looking for intracranial hemorrhages, and if it doesn't show up on CAT scan, that doesn't mean it's not there, it just either means that we caught it too soon, or it's so small that we need to do the higher resolution MRI to really rule out that that patient did not have a stroke. But before we do that MRI, we need to make sure that we're treating them appropriately, i.e. screening their swallowing. Okay.
Where's that charted?
Good question. So after the policy page, there's a screenshot in here on where to chart. It is an ad hoc power form, so are you all familiar where ad hoc is up at the top of FirstNet? The power form is titled Swallow Screening at Bedside for Nursing. It's the very last one. Okay. It's a 3-page form. So the first page here talks about reasons that you would not screen this person, okay? So for example, if the patient's unable to remain alert, they come in altered mental status and they're completely unconscious, we're not gonna screen that person, we're just gonna leave them NPO because they can't follow commands, alrighty? If they're completely aphasic, if you're like, I need you to drink this water, and they're the person that's climbing out of bed, we're just gonna leave them NPO. We can't screen that person because they can't follow commands. If they come in on a modified diet, like they come in from the nursing home, thickened liquids, honey and nectar thick, I would probably wait for speech therapy to see that person because the screen is only validated with thin water. Okay, so we can't thicken the water and the screen be valid. If they have a PEG or a G-tube or something like that, we're probably just going to use that, but if you do give them anything by mouth, we do need to screen them. If we can't raise the head of the bed, maybe they're a trauma and a stroke, you know, they're on spinal precautions, just leave them NPO. If they're a new trach, or if they're NPO by physician order, like maybe they're going back for surgery or something like that, where the physician says just leave them NPO. Just leave them NPO, and upstairs can screen them, okay? If you don't have to give anything PO and the patient doesn't ask for anything, you can also just leave them NPO, and you can let upstairs worry about it. That's alright, because they get the same training that I'm talking about right now. If none of those apply to the patient, you can leave that first part blank. Okay, you don't have to fill anything out. The second page, there's 3 tabs up in the upper left-hand corner right here. So that was the first tab. The second tab explains how to do the swallow screen. So if you can't commit this to memory, that's okay. It's built right into the documentation. 90 cc's of water, continuous gulps. The bottom part is for Memorial Hospital only. They do a couple of labial motor exercises that aren't necessarily part of the screen. You can do them, but it's not required. And then finally, the third tab is the most important. This is the only part you need to fill out. It's pass or fail. Okay? So did the patient drink the water, and did they not? And it even tells you what to do depending on that result. Okay?
So this would obviously be before we gave any of these, right?
Correct. You need to make sure that this is documented before you scan your meds. Because if you do it the other way, it looks like you gave a pill and then did a swallow scan,
Yeah.
which doesn't make any sense. If this is missed, you might get an email from me. It's not punitive. I just like to ask sometimes because a lot of times people do the screen and just forget to document it. And if you forget to document, you can put it in later and it still counts. Okay. So if you get an email that says query nursing bedside swallow screen, don't be intimidated by it. It's just like, hey, did you do it or not? And if so, you know, can you put it in? So, any questions on the swallow screen? Alrighty.
Does that require a physician order, or can you just do that? Okay, just a
No,
nursing
that's nurse
judgment.
driven. You can screen
Okay.
anyone, trauma patient, you know, go at it. If the patient passes, speech therapy doesn't even need to see them. If they have language or cognitive problems, they will follow them for that, but if they pass the screen and there's a speech therapy order, they'll cancel it. Because again, there's a 95% confidence with this test. It seems simple, but it really works when done properly. Alrighty, back to the checklist on the front page. So basically, once neurology gets on board, whether it be myself and the in-house neurologist or a specialist on call, again, we're just trying to determine, can we give the patient TPA? Can we transfer them for thrombectomy? So with TPA, basically one of the most important things is getting that weight. And pharmacy, when we have the clinical pharmacist in-house, usually they will go ahead and take over mixing TPA for you. But if it's after hours, I will show a short video on how to mix TPA and talk about that a little bit. But if we are going the route of TPA, if the patient presents within 4.5 hours of their time last known well, we need to make sure that their blood pressure is less than 180/105. Okay, a lot of these patients come in the 200s, so if we are considering TPA, we need to make sure we get that blood pressure down. Okay, so you can try a one-time dose of labetalol, see how that works. My rule of thumb is if that doesn't work, get them on a cardine drip, because they're going to go to the ICU anyway. Okay. The thing is with PRNs, their blood pressure will go down, and it wears off, and it'll go back up. And so with cardine, you can level them off rather than the spikes up and down. Once we give TPA, we move to a paper flow sheet. So there is a TPA section in the binder here. There is the indications and contraindications, which the neurologist will review this with the patient, but if you want to know what they are in here for your reference. There is a dosing guide, which we'll talk about a little bit once we get to the video on how to mix TPA. And then there's a guide on how to program the IV pump, which I'll talk about here in a second. The most important thing for you is the paper flow sheet, because once we give TPA, our vital signs and neurochecks are very, very specific. The Joint Commission literally looks at these one by one. So we tried doing it in Cerner, and for whatever reason, people just can't get it right. So once we move to the paper flow sheet, people do a better job with, because if you leave blank spots, you know you're not doing what you're supposed to be doing. So this checklist here is in the code stroke binder, so if you give TPA, you're gonna wanna pull one of these, okay? The front tells you what your blood pressure parameters are and how often you need to do vital signs and neurochecks. It's basically a 2-page form that follows the patient for 24 hours, so this will go with them up to critical care. Basically, the top of the form here lists how often we do the check, so we do it Q15 for 2 hours, Q30 minutes for 6 hours, Q hour for 16 hours, okay, for 24 hours. So basically, 15 minutes, 30 minutes, 45 minutes, 1 hour, an hour and 15, hour 30, and it goes all the way through 24 hours. Okay. There's 2 rows up here at the top where you can write in the time that the check is due, and then the time that it's actually done. Okay. We usually allow 5-minute gaps, so try to get your patient onto the even hour. So if you give TPA at 14:50, just do your next check at 1500, then 1500, 15:15, 15:30, 15:45, 1600. That way we're not trying to do checks at like 16:57 and 18:02, things like that. But so you can kind of round, and when you actually do the check, you have a 5-minute window to do it within the time. This is basically a modified NIH stroke scale. You do not need to be certified to do this assessment, but basically it asks about the patient's level of consciousness. So if the patient, there's a 3-score rating system, so a 0 is that they're alert, 1 is that they're not alert, but it's pretty easy to wake them up, 2 is that they're not alert and you maybe have to do a sternal rub or something to wake them up, and then 3 is that they're completely unresponsive. Level of consciousness questions: how old are you? What month is it right now? If they answer both right, that's a 0. If they get 1 incorrect, that's a 1. If they miss both, that's a 2. Level of consciousness commands: give me a thumbs up, close your eyes real tight, open them back up again, some simple 2-step process. If they can do both, that's a 0. If they miss 1, that's a 1. If they miss both, that's a 2. Aphasia: so usually I just have the NIHSS cards out and I just show them the picture, tell me what you see. If they have no aphasia, that's a 0. If they have some mild aphasia, that's a 1. If they have pretty bad, moderate to severe aphasia, that's a 2. And if they're completely mute or just not making sense at all, that's a 3. And then finally, the arm and leg strength. So basically each limb is scored individually. For the arms, they have to be able to hold it up for 10 seconds. For the legs, it's 5. So with the arms, if there's a drift, but it does not hit the bed, that's a 1. If it drifts and hits the bed before 10 seconds, or 5 seconds for the legs, that's a 2. If they can barely move it at all, like they can't really lift it, that's a 3. And if there's no movement, even to painful stimuli, that's a 4. Okay, so again, 0, if it drifts but doesn't hit, that's a 1. If it drifts and hits, that's a 2. If they can't really lift it but can move it, that's a 3. And if there's no movement, that's a 4. Okay, each one of those is scored individually.
Now, if you let go of their arm and they drop it slightly, but then it doesn't move after that, do you count it?
That would count as drift.
It would, okay.
Basically what I do is I hold my hand at the same level and see what happens. Okay. So you total up their score, and what we're looking for the patient is to get better, not worse. Okay. And then we have a spot for blood pressure, heart rate, respirations, and oxygen, and then your initials. And then this will follow the patient. Okay. You can still document nursing narrative notes, but once we start TPA, this is really the only documentation you need to worry about. Okay. Any questions on that?
How often is TPA given in the emergency department?
We gave 40 last year.
Oh, that's not a ton.
How long does it take to infuse?
1 hour. And we'll talk about that. There's an example of the form in the binder, so if you want to see what this looks like filled out, there's an example here. And there's also a blank copy for whatever reason if all the blanks, I usually do a pretty good job keeping this stocked up, but if you need to make a copy, there is an original in here too. Okay. All right, going back to TPA dosing. We'll watch the video here at the end, but basically TPA is weight-based dosing. It is 0.9 milligrams per kilogram. As long as you have the patient's weight entered into Cerner, it'll calculate it for you. But pharmacy and myself, we usually like to do it just by hand real quick too, just to verify that Cerner is doing what it's supposed to do, just because it is a high-risk drug. The maximum dose you can get with TPA is 90 milligrams. So if you're 100 kilograms or more, you're going to get that full 90 milligram dose. If you're less than 100 kilos, you're going to be dosed based on weight. Okay. 10% of the total dose that you're going to get is given as an IV pump bolus over 1 minute, and the remainder is going to infuse over 1 hour. Okay. When you are programming the IV pump, you're going to type in AL for Alteplase. That's the generic name for TPA is Alteplase. It's not under TPA. So AL is what you're looking for. Again, there are pictures in here to guide you on how to do that. There's going to be 2 options. One of them is Alteplase greater than 100 kilos, and then the other option is less than or equal to 100 kilos. So if your patient's 105 kilos, you don't need to worry about the weight. They're going to get that full 90 milligram dose, and the pump is not going to ask you for the weight. But if they're less than or equal to 100 kilos, the pump is going to ask you for the patient's weight, and it'll program it automatically, including the bolus. Okay, so I do teach it, but everything is automatic. Alrighty. The only thing that you have to program on the pump is the volume to be infused, which will always be equal to the rate. So for whatever reason, the pump always leaves the volume to be infused as 0. So basically it's going to be equal to whatever rate that the pump calculates. So in this example, it was a 47.1 milliliters per hour, and the volume to be infused will be the same thing because it's going to go over 1 hour. Okay, so you'll have to type that in, but that's the only thing you really have to do.
So when you're giving that bolus, because, there's the IV tubing,
Mhm.
right? And so if it's 10% of if you're given 90 mLs, so 10% of it's 9 mLs, how do you, if you're not priming it with,
You're
'cause
priming.
okay, so is it on a syringe, or is it in a bag?
It's in a bottle.
It's in a vial, and you
Mhm.
just spike the vial?
Yep, you just spike
and
the
you
vial.
prime it with the TPA?
You prime it with the TPA.
Okay, so you're not mixing it, you're not infusing it with saline or
Nope.
anything, wine it in, okay, alright.
And
That's my
the video
question.
does a lot better job at explaining.
Okay, alright, okay.
And it'll give you a little bit visual. I did bring one that you
Use the
guys can look at and play with once we get to that. So yeah, the pump will deliver that bolus automatically. So yeah, for the 100 kilogram or more patient, it's going to be that 9 milligrams. If they're less than 100 kilos, it's gonna be weight dose.
Okay, alright.
So like for your little 50 kilogram people, you know, your vial's gonna actually look like it's almost empty.
Sure.
The important thing with TPA is that we always remove the dose that we're not going to give the patient. We're always gonna run TPA dry. So even if you have a 100 kilogram patient, you're gonna automatically withdraw 10 cc's from that vial. Because again, the maximum dose that they can receive is 90 milligrams. It's a 100 milligram vial, a 1-to-1 ratio. Okay. If it's a weight-based dose, you're gonna remove whatever waste from that vial based on that patient's weight. And again, the video will explain that a little bit more clear, but I just wanna talk through it first, and then I'll show that. So, any questions on that? Alright, before I show that, I'm gonna talk about thrombectomy. If that patient's NIH is 6 or greater, or their FAST-TD score is 4 or greater, we have to find out, do they have a large vessel occlusion, okay? So the scores tell us that they might, but the way that we find out is we do a CT angiogram of the head and neck. Okay, we're looking for any big blood clots in the neck, any big blood clots in the brain. So we will work the patient up in the ER room, and then if their score is 6 or greater, we're gonna go back to CAT scan to get that CTA of the head and neck. Okay, and we'll do this after we start TPA. Our goal is to always start TPA first, and then we'll go back to CT, because our goal is to give TPA within 30 to 45 minutes of when the patient comes in. So when they hit the door, that's time 0, okay? So what we're gonna do is we're gonna go back to CAT scan, stat, we're gonna get a CTA of the head and neck, and then we're gonna have the radiologist look to see if they have a large vessel occlusion. If not, we're done with the code stroke. Okay, we're gonna get them over to critical care if they got TPA. If not, they'll go to NC or short stay. If the CTA does show a large vessel occlusion, the ER physician is gonna tell the secretary to call the Beacon Transfer Service. We're gonna usually get Tri-County or one of our ambulances over here, because the patient is gonna go to Memorial Hospital to their emergency department, and from their emergency department to the interventional radiology suite. The ER physician is also going to talk to the interventional radiologist over at Memorial, and they're gonna accept that patient for transfer. And then really the thing that you guys have to worry about is the transfer paperwork, and then calling report to the ER nurse over at Memorial Hospital, okay? Our goal is really to get the patient over to Memorial as quickly as possible. So the sooner that we can call Tri-County, the sooner that we can call Transfer Direct at Memorial Hospital and get everyone kind of alerted that we have a patient that needs to go, the better. We don't want these patients sitting in the ER for 3 or 4 hours waiting on transfer. Okay, this is a stat. Every 15 minutes that we lose decreases the probability the patient's gonna walk again. Okay. So our fastest time was 61 minutes from door to out, but we do typically take 3 to 4 hours. And that's just because I called Memorial, have we called Tri-County yet? Oh no, let me call Tri-County, so, you know, they can take up to a half hour to get to us when they get here, and, you know, everyone's just kind of loitering around. It's like, no, load them up and go, right? So just this is more of a thing after hours, but really try to push your patient along, okay? We shouldn't be just standing around twiddling our thumbs, like, what are we waiting on? What are we, you know, waiting to hear back from? The other thing is that if the patient is an intracerebral hemorrhage, if that initial head CT shows a hemorrhage, again, typically we're going to cancel that code stroke, get their blood pressure down below 140 as quickly as possible, get Cardine on board, because the higher the pressure, the more bleeding we're going to have, okay? If they're on any anticoagulants, we may reverse those, so, you know, that's your Kcentra, your FFP, your vitamin K, your factor V, those types of drugs. And then we're going to call neurosurgery and see if we need to take them to the OR. Okay? All right. And that's kind of the end of the checklist. So, any questions? Other things that are in the binder to help you. We have a phone listing. Okay? So these are all the phone numbers that we commonly use during code stroke. My contact information is up here. If it is after hours, the best way to get a hold of me is on Doc Halo. So if any of you guys are on Doc Halo, if your charge nurses are on Doc Halo, that's a good way to get a hold of me. All the fax numbers for the units are in here. Our full code stroke policy is in here, so this is kind of long. Excuse me. But if you have any questions about what to do during a code stroke, the full policy is in here, as well as the clinical algorithm, our FAST-TB score, all of our criteria for IVTPA, the criteria for mechanical thrombectomy, and then the checklist. So if you have questions, the binder is a good place to start. Alrighty. So now we will talk about mixing TPA. So this is how TPA comes. This costs $164,000.
Crap.
So they don't tube it. If you're in a bind, yeah. Pharmacy will mix, the basement pharmacy will mix this for you, but that does take a little bit of time. We do keep this in the Omnicell in the ER. So the fastest way we can get this to the patient is just pulling the ER's TPA and mixing it at the bedside, okay? But if you really feel uncomfortable, if there's nobody in the department that feels comfortable, you can call the basement pharmacy if it's 3 in the morning, because our clinical pharmacist is only there until I think 1 in the morning, or is it 11, something like that. But they will mix it if they're there, but if it's like 3 in the morning, you know, you can utilize the basement. But ideally, we should try to mix this at the bedside because you're gonna get it to the patient faster, alrighty? You have 2 vials. You have the drug vial, and then you have the diluent, and then you have this little double spiky thing here. So basically what you're gonna do, this is gonna be a dry powder in this vial here. So basically what you're gonna do is spike your powder first, take the other cap off, and then spike your water, and then you're gonna flip. And then it's gonna drain out. What you don't wanna do is spike water first, and then dump your water, cause it's gonna spill. Okay, so always do it the other way, powder on top, and then spike your, like that, okay? So this will take a couple of seconds to drain out. They recommend this sits for 3 minutes to mix, but yeah, I'm very impatient. Usually I'm doing this. You know, once this is empty, you can go ahead and throw that away, but usually I'm doing this to try to get that powder to mix, okay? After this is all mixed, there's no more clumps, you know, like Zosyn. You can spike your tubing, prime your tubing, get a 10 cc syringe. Basically, you're always gonna pull out 10 cc's because the maximum dose is gonna be 90 milligrams. This is a 100 milligram vial. It's a 1-to-1 ratio, 1 milliliter to 1 milligram. If your patient's 100 kilos or more, they're gonna get the rest that's in here, the full 90 milligrams. If they're like 54 kilos, we'll look at Cerner, see what the weight calculation was. We can look in the binder. There's a dosing grid under TPA here where we can look at the patient's weight. So for, let's see, 50 kilograms, that's gonna be, there it is. It's gonna be 45 cc's is gonna be the total dose. So we're gonna remove 55. Okay.
That's what I was gonna ask, do you remove the 55 or do you set your pump to 45?
We remove it. We're gonna
Okay.
remove the 55.
Okay.
And then we would program the volume to be infused for 45
Okay.
in the pump. Okay.
Now, is that something you need an order for, or is that something we can just look at and dose it?
TPA will come from the physician.
Okay.
It'll be a physician order because the neurologist will have to say yes or no.
Right.
It's
to get-
$164,000. So in my experience, and I don't know, I haven't worked with TPA, and maybe you're gonna get to this, Kyle, and I'm being
No.
presumptuous, but, so when you're spiking it with IV tubing, right? Just normal IV tubing?
Mm-hmm.
So, and maybe these vials are a little bit different, but like if this is your normal IV tubing little thing,
Mhm.
right? Like, let's pretend this is IV tubing. Like, there's always some left down here
Mm-hmm.
at the bottom. So is the patient really getting the whole dose if there's some left down there because you're withdrawing what
Yep.
you're not giving?
That's a good point. That's a good segue. So basically, once that vial runs dry, try to do this little number,
Okay.
you know, to get that. There's a little window there so you can kind of see how much is going to be left. But after this runs dry, take this off, get a bag of normal saline, spike it on there, run it at the same rate. That way you flush the tubing.
Okay.
So if it's running at 90 cc's an hour, just run it at 90 cc's for, 15-20 minutes or something to make sure that that full drug goes into the patient.
So don't let your tubing go dry.
Correct.
So if they
Okay.
are 45, if they get 45 cc's, it's 45 cc's an hour then
Mhm.
too? Okay.
And you guys can play with this, and then I'll get the video on. Where did my
think he's looking
Oh,
at
sorry,
that.
I stole it.
I
Yeah,
keep
it's
losing.
blending in.
Yep,
It's
so,
transparent.
yeah, you guys can play with that, get some hands-on, and I'm gonna pull up the mixing video. Genentech does a way better job of explaining it.
I don't know how to pause this, but oh well. I don't want to stop the whole video. Can you zoom
Go
in?
dry in like a second.
You know, make it go in there. About 2 weeks already.
He's putting it on the TV.
Oh, we didn't get it all.
Oh,
You're like,
You're like, now what do I do?
I don't know, I'll just pull it up on the laptop here and show you.
I actually
I'm sure there's a
watched
way to
a
put it on the
video
TV, but
on this,
no,
it's
this
so
computer's
fun.
gonna
Just
take
kidding.
You can
Yeah.
just hook that to right to your laptop and put it right into the TV. That's what Brooke does.
Oh, okay.
It's the other part that's
Oh, it's
fun.
inside.
I know, I'm like, this is not hard.
It's the, drawing
Administration.
up the 55 to throw away, or,
Yeah,
you know.
and then like making sure your tubing doesn't go dry and then like just stand there.
Well, they're pretty much always.
Oh, is there one end? Oh, never mind, just kidding, they're both the same.
There's not a remote sitting somewhere.
Now you gotta use the
The
button
little thing
underneath.
at the bottom, like just push that middle button, I guess. There you go, maybe.
Do you guys want this?
Oh yeah, there you go.
No, I'm good.
And then there's like this thing, I don't know, whatever. And then push it again, I think. Oh no, just kidding. Then there was like something that popped up.
Hold the button down in the center.
I'll hold it down. And
These
the
TVs are weird. There's a toggle.
No, it was like she like,
Our
did she
Beds to
hold
Beds
it?
program allows you to have your prescriptions filled in our outpatient pharmacy.
You looking for the menu?
And then
Yeah.
Yeah, just so I can
It's
just
just like a
visually
one
arrange.
touch.
Time for you to go
Is it
home.
Boom.
To the,
Not
Just,
only
the big
just go
circle
straight
toggle?
up. Touch the toggle straight up.
Yeah.
But
We
it
did
also
that.
allows
Yeah, there you go.
There we go.
Answer
Yeah.
any questions you might have about your medications.
It's like
There you
two
go.
How many
technologically
people-
advanced.
But it's,
Okay,
it's like
wait.
they got a big square and then a little
Yeah.
square.
I want
and,
me
and
and Kayla
like
to.
big fingered
It is-
people
It's a weird.
and no nail people, no
Sorry, I
nails.
was not helpful at all for that.
No, that was helpful. Yeah, we figured it out.
I don't know, my TV just has it on and off, but.
Most
Sure,
TVs
that'll
have
be
remotes.
fine.
so-
I was just trying to make it a little more center. See how it's down like that?
Oh, I feel like I didn't watch this one.
Now that we've set out the material and calculated the dose, let's go over the step-by-step reconstitution process for Activase. It's important to reconstitute Activase immediately before administration using only sterile water for injection, USP, without preservatives, and the transfer device, which are provided in the Activase package. Begin by removing the protective caps of the Activase powder and the sterile water for injection and swab the top of each vial with an alcohol wipe to reduce the risk of contamination. Notice the center of the stopper is where the transfer device is inserted. The keyhole port is for the needle to withdraw the discard dose and bolus dose. Then remove the transfer device from its wrapper and remove the protective cap from one end. Insert the piercing pin vertically into the stopper of the sterile water for injection, keeping the vial upright. Remove the protective cap from the other end of the transfer device. Holding the vial of Activase upside down, position it so the center of the stopper is directly over the exposed pin of the transfer device. Push the vial of Activase down onto the transfer device, making sure the device is pierced through the center of the Activase vial stopper. Invert the two vials so the vial of Activase is on the bottom and the sterile water for injection is on top. Allow the entire contents of this sterile water for injection to flow down into the Activase vial. Remove the vial of sterile water for injection and the transfer device from the Activase vial. Safely discard the transfer device and the diluent vial. Mix the solution with a gentle swirl or slow inversion. Do not shake the Activase vial. It's normal for slight foaming to occur. Allow the solution to stand undisturbed for several minutes to allow large bubbles to dissipate. Remember, no medications should be added to infusion solutions containing Activase, and any unused solution should be discarded. Dosing and administration using 100 milligram vials. Now that we've calculated the dose and successfully reconstituted the 100 milligram vial of Activase, Let's move on to administration using the sample calculations for our 180-pound or 81.8 kilogram patient as a guide. To review, the discard quantity for our sample patient is 26.4 milligrams or milliliter equivalent. This is the excess quantity that should be withdrawn from the 100 milligram vial and discarded before administering Activase. Remember, these calculations are based on the FDA-approved dose of Activase, 0.9 milligrams per kilogram. The total dose should not exceed 90 milligrams. 10% of the total dose should be administered as an initial bolus over 1 minute. The remaining dose should be infused intravenously over 60 minutes. Visually inspect the Activase solution for particulate matter and discoloration before administration. To ensure proper dosing, discard excess by removing the excess drug from the Activase vial. To remove the discard quantity of 26.4 milliliters, slightly tilt the vial and insert the needle into the keyhole port of the vial top, away from the puncture site made by the transfer device. Do not prime the syringe with air. There is also an alternative method
This is
where you
easier.
can prepare the infusion set and remove excess from the Y-side injection port. It is important to properly discard the excess quantity. Next, prepare the bolus dose. The bolus dose is 10% of the 0.9 milligrams per kilogram dose. In this case, remove 7.4 milligrams or milliliters. Prepare it one of the following ways. Using a syringe and a needle, remove the dose from the Y-side injection port on the infusion line after the infusion set is primed. Or, remove the dose from the vial before the vial is attached to the infusion set. Be sure to insert the needle into the keyhole port of the vial top, away from the puncture site made by the transfer device. Do not prime the syringe with air. Now, insert the spike from the infusion set
We're
through
just
the
gonna
center
bolus
of the
from the pump,
stopper of the
so you don't
vial
have
of
to worry about
reconstituted
getting a
Activase,
syringe
using
for
the same
that.
puncture site made by the transfer device. Peel the clear plastic hanger from the vial label and hang the Activase vial from the resulting loop. Prime vented infusion tubing with Activase solution. Then administer initial IV bolus over 1 minute. Administer the IV bolus directly through the Y-site injection port of the vented IV tubing, or program the infusion pump to deliver the bolus dose. Immediately following the bolus dose, infuse the remaining 90% of the 0.9 milligrams per kilogram dose over 60 minutes. In this case, the infusion dose would be 66.2 milligrams or milliliters. Lastly, to ensure the full dose is delivered, spike a small bag, for example, 100 milliliters of 0.9% sodium chloride USP, with the end of the Activase infusion set when the Activase vial is empty, and continue the infusion at the same rate.
Alright.
Follow-up care for Activase patients is critical.
So you can use a normal, like, Polaris pump
Mm-hmm.
for, it'll be in the program?
Yep.
Okay.
It's under Altaplace, so you're gonna type in AL. And that will get you to what you need. Alrighty. That is pretty much all I have. Do you guys have any questions or? Well, thank you very much for your time, and if you have any questions, please just don't hesitate to get a hold of me. Again, my contact information's in the binder here. My email is kberry, B-E-R-R-Y, or .kalo. That's another good way to get a hold of me too. So, and I'm sure I'll be seeing you around. So,